All right. Good afternoon, everyone. This is James Tatum with the Council of State Governments, and I want to thank you for joining us for our continuing coverage of the occupational licensing policy response to COVID-19. Today, we'll focus on the efficacy of responses from state licensing bodies and compacts. We are recording this webinar, and that recording will be made available on our project website at licensing.csg.org, and we'll post that URL at the end of the presentation for your reference. We encourage everybody to submit questions for the presenters through the Zoom chat, and we will be holding those for the end of the presentation. By March 17th of last year, every state was under a state of emergency, and were under tremendous pressure to increase healthcare capacity. Many states faced healthcare worker shortages even before the pandemic, and stay-at-home orders and social distancing measures slowed the licensing process by making it difficult to administer background checks and closing licensing offices, testing centers, and continuing education providers. Public health measures also affected the availability of treatment, from general practitioners to mental health providers. In response, governors, legislators, and regulators issued emergency provisions which CSG collected and categorized in a database. By the end of July last year, we had identified 108 actions that modified license requirements, 181 concerning temporary licensure, 74 expanding or redefining telehealth, and 44 that modified scope of practice. That database is available on our website with the URL there, and that breaks the provisions down by category and by state. But using that data, CSG published the report assessing COVID-19 occupational licensing policy actions, where we analyzed those policy actions and developed 3 strategies to help states improve resiliency in the future. First, an expansion of telehealth practice can increase resiliency and also enhances access to healthcare services for people in rural areas and along state borders. Online licensing systems were a focus of many states before the pandemic and serve to reduce the time it takes to obtain a license by cutting down on in-person appointments and physical mail, and of course offers a contactless experience for the vast majority of users. Finally, improving licensure portability can help states meet healthcare demands by helping practitioners to move to areas of greater demand for their services with less difficulty. The added benefits of using interstate compacts to improve portability include national databases of practitioner information and a decreased amount of time waiting to become licensed in many states. Now that these temporary licensing policies have been in place for almost a year, we suggest that states evaluate how these policies have changed healthcare capacity and access, and look for opportunities to make positive changes to their regulations moving forward. Today, our speakers will review policies in their states that have had the most positive effects in response to COVID-19, and the Executive Director of the Interstate Medical Licensure Compact Commission will tell us more about the roles of compacts and medical practitioners. This leads me to our first speaker today. Jamie Doming is the Executive Director of the Louisiana Licensed Professional Counselors Board of Examiners and is responsible for overseeing the administrative work of board staff. She holds an MBA with a concentration in finance from the University of New Orleans and a BS in business from Louisiana State University. She has worked in previous roles to serve her community as the Director of Programs for the largest educational nonprofit in the world, and on the board of directors for Sunrise Rotary of Baton Rouge. We're glad to welcome Jamie to talk to us about actions taken by Louisiana. Jamie?
Hi, good afternoon. Thank you. Thank you, James, for that introduction. I hope everyone's doing well today. I'm going to spend the next 15 minutes providing some information in regard to how our state handled the pandemic and also how our board handled the pandemic. So I named this presentation A Changing Landscape because after the last year, I think it's pretty clear to see that the landscape is changing. So James, do I have control now of the screen? Let me see if I can move this forward. James, do you mind hitting that next forward? moving forward for me?
Certainly, I'll take care of that for you.
Thank you. So when I started thinking about this and considering what would be the best information to discuss today and provide to you all, I started thinking about innovation and technology, because really they go hand in hand. And so as we sit here and ponder what's going to be next, or how we can be on top of things, we have to consider, is technology and innovation shaping policy changes, or is it the inverse? I also had to consider, as I thought through this presentation, is our foundation capable of change? Is your foundation capable of change? Does your licensing board statutes provide flexibility and allowing more portability through rule changes? And also the legislative climate change and the opportunity that we currently have to innovate as we move forward coming out of this pandemic. Next slide, please. So I'm going to start with the leadership and action of the state. On March 11th, 2020, Governor John Bel Edwards declares a state of emergency. I have listed that Louisiana revised statute so that if you're interested, you can refer to that statute in regard to the language. Moving forward, I tried to list that language so that you all would be able to refer to it. I know many times when I'm trying to write new rules or regulations, it's very helpful if I can refer to someone else's language. It kind of moves the process along a little bit quicker. So please go ahead and as we move forward, if you want to jot these statutes down so that you have that information moving forward to refer to when you're trying to write your own policies. On March 21st, 2020, our state health officer, Jimmy Guidry, sent us a memo from the Louisiana Department of Health. He was directing all healthcare services to transition to healthcare as the primary mode of treatment that would be effective immediately. On March 22nd, our stay-at-home order was initiated by the governor, and that was extended through May 15th of 2020, and that is when the stay-at-home order was lifted. Next slide, please. So here is a list of how our board responded to this emergency. On March the 20th, 2020, our board convened via Zoom. This was all in accordance with Louisiana Revised Statute 29760. Again, that's listed in case you want to refer to that information. This was in accordance with the Public Health Emergencies Power Act to approve emergency plans. So our board came together, we met via Zoom, and we had an emergency meeting and said, what are we going to do? What can we do for our licensees, and how can we best serve the public? So all teletherapy rules were rescinded via emergency rules and published in the Louisiana State Register. This was all in accordance with the Administrative Procedures Act, the APA. And again, that language is there for you to refer to. I always don't want to, I don't want to believe that everyone has the same policies and rules and regulations. So I try to act accordingly and make sure that you have that information in case this is something that you're interested in. Your state may not currently have this, or your board may not currently have this regulation. And so this is an opportunity to look at what this state does and those statutes so that you can use this moving forward if you don't have these policies in place. On July 20th, we actually promulgated new rules, and we noticed the state and the Louisiana State Register that would, and these rules would decrease teletherapy regulation once the emergency rules expired. So when we entered into the pandemic, we came together as a board and we lifted all of our teletherapy regulation. We said there's not going to be any regulation. We're going to allow licensees to practice within the state of Louisiana. We're not going to require continuing education. We're not going to have any requirements. All rules were rescinded. Once we got a few months into the pandemic, we realized it would be important for us to make some changes to those rules. And so that's why we published the new rules. And I'll talk a little bit about that in a few minutes. But on July 20th, 2020, new rules were promulgated and noticed to the public. December 20th, the rules were finalized and published in the Louisiana State Register. Our state, it takes a little bit of time to get some new rules published. And I will say, I'm not sure how many states have this. I think there's only a handful, but we actually have an oversight committee through legislation. And then we actually have an occupational licensing regulatory commission that we have to go before to present rules. Then we're allowed to notice those to the public. The public has 30 days to respond. Once the public responds to those publications that are in our state register, I have to take back the rules to the oversight commission, the occupational oversight commission, present those rules again and get a second final approval. Now, once I get that approval, then I can go to the oversight committees, which is the health, the health and welfare, the House, the legislative, all of the committees, and that's all done via writing. Once I get that approval, then our board can move forward with rules. And so our rule process is a little bit different probably than many states, because I don't think there's that much oversight. But if you're interested, that is how our state promulgates new rules. We have oversight committees, and we also have an occupational licensing regulatory commission. Next slide, please. Okay, so once our emergency rules are lifted, which currently they're set to expire March 31st. Now, if our governor decides to extend the state of emergency, then we will continue our emergency rules. Our emergency rules are basically no rules. So right now we have no rules on telehealth. But when the rules do go back into place, like I said, we just promulgated new rules. And this is the basic requirements of what those new rules will look like. So the board will now accept all licensees practicing telehealth at the time of licensure. Previously, you had to be licensed for a year before you could practice teletherapy. The board also will require 3 hours of continuing education or graduate coursework. Before it was 9 hours. The board will also accept 3 hours of continuing education with each renewal period. As a licensure board, we renew license every 2 years. I know that varies amongst boards, but our board renews license every 2 years. The new rules will also allow for 100% of supervision hours to be online, as long as it's a HIPAA compliant platform. Previously, our licensees could only do 25% of supervision online. Board approval is still required to practice teletherapy, and we'll discuss this a little bit, in a few minutes. Mostly, it's very difficult to capture who's practicing in your state if there's no regulation. And so we do require board approval. We need to know if you're practicing and providing telehealth. And there are no fees that are required. So this is not an application process. We do not ask our licensees to pay a fee to get licensed or have that certification to provide telehealth. We just ask that you provide us this information so that we can put it into our system that you are providing telehealth. Next slide, please. So I thought it was very important to discuss effective communication on rule changes, because let's be honest, a lot of the public, a lot of the licensees are not reading our 100 pages of rules every day on a regular basis. So we have got to figure out across the nation how we can effectively communicate when there's a change or something significant happening within the agency or the rules and regulations of that licensing board. And that's why it really is very important that the foundation of your agency has technology, because if you're still paper-based, it's very, very difficult to have that portability to change any software, to change any communication. And so that's why I thought it would be important that we had a conversation on effective communication. So of course, like I mentioned before, I did list those revised statutes for emergency rules. We do have the authority to write emergency rules, which we did. We do have the authority to provide temporary licensure for 60 days within the state if there's a state of emergency. Technologically, we were very capable. We are one of the first licensing boards in the state of Louisiana that accepts all applications online. We even have a functionality to where supervisors can approve information across the platform. So everything is fully portable. There are no paper applications. Nothing requires paper within our agency. State licensing boards communicating with the professional associations. Once again, it's important to know who your professional associations are and have a relationship with those professional associations so that information can be disseminated a little more quickly. Do licensing boards have current contact information? And if they don't, is there a regulation that finds them or that requires them to have that information up to date? Our board does have a requirement that we have to be notified of any change in physical location or contact information. And our licensees pay a fine of $50 if for some reason we send them an email and it comes back to us and we don't have another way to contact them on file at the board office, or if we send mail to them, which slowly, hopefully we will be moving entirely away from snail mail. But right now, if we do have mail sent back to us, it is also a fine if we don't have their physical location up to date with the board. Okay, next slide, please. So here are our numbers for the state of Louisiana. Like I said, it's very difficult if you don't have any regulation to be able to track how many licensees are practicing telehealth. And these are just a few of the numbers that we were able to pull out of our system. Currently, we have around 6,300 licensed professionals in the state of Louisiana. We started telehealth regulation in May of 2019, which for mental health professionals, we were the first to even initiate any regulation in regard to telehealth. And as I mentioned before, there's no fee to do telehealth. There's no application process. It's just a notification so that we know who's practicing, because if we don't know, I wouldn't even be able to provide these numbers to you today. So we did rescind all telehealth regulation as discussed a few minutes ago, and our current registered licensees using telehealth is about 21%. Now, again, we rescinded all of this regulation. So over the last year, we probably don't have as many numbers that there probably were more because there was no regulation during the COVID crisis. But registered as of today, 21% are registered to be providing telehealth. But the current challenge is knowing how many patients are being treated by out-of-state licensees via telehealth. So once again, if they're not registered within the state, we don't have the information, it's very hard for us to know how many people are being treated by telehealth in the state of Louisiana right now. Another issue would be complaints and ethical violations in our jurisdiction, because we have little recourse for action if they were performed via telehealth. I will say that in the last year, we have not received a single complaint in regard to telehealth. So that's a very positive fact that I would like to provide. So we have not had any complaints in regard to telehealth. But if we do, there's little recourse for action if there's no regulation or if we don't require people to at least be registered. And once again, federal regulation supersedes our state statutes and our board rules. Next slide, please. So here are our future challenges with teletherapy regulation. We do hope that soon we will see a licensure compact. We also are having some issues, as I said, trying to track complaints or ethical violations if they do occur via telehealth. Again, it's a matter of jurisdiction. If the licensee is practicing out of state and providing teletherapy to a patient within the state lines of Louisiana, it's difficult when you're trying to work through those types of complaints or ethical violations. Cohesiveness with HIPAA regulation, trying to be in compliance with those changing rules and laws. And then federal legislation and compatibility with our current state legislation. So those are our future challenges that I foresee. Again, it's a changing landscape. I think it's going to change much faster, especially after this pandemic. We're jumping 10 years technology-wise ahead real quick. So we got a lot of work to do, and the landscape is definitely changing. Next slide, please. I think yes, this concludes my presentation. Thank you all for joining in and listening, and I'm happy to take any questions at the end of this presentation.
Yes, thank you, Jamie. And yeah, if you do have any questions for Jamie, just feel free to post that in the Zoom chat, and we'll relay those after the webinar. Our next speaker today will be Melissa Clayman, who serves as a senior policy advisor to the South Dakota Governor's Office for the Department of Social Services, the Department of Health, and the Department of Human Services. Before joining the Governor's Office, Melissa worked for the South Dakota Department of Labor and Regulation, most recently as the Deputy Director for the Division of Insurance, where she focused on health insurance. Melissa holds a bachelor's degree in criminal justice from Colorado Technical University. Thank you, Melissa, and go ahead.
Thank you, and good afternoon, everyone. Again, my name is Melissa Clayman, and I'm a senior policy advisor with Governor Noem's office here in South Dakota. Wanted to hit on a few things that South Dakota did during the pandemic as being a senior policy advisor and having the health area, and then also through social services. There were many things that we encountered in the first days that have just extended there beyond. On March 13th, Friday the 13th for us here in South Dakota is when Governor Noem did declare that state of emergency. That from that point, we began, as different entities began to close licensing facilities in the state, and then also as individuals and the health profession started to come down with COVID, we began to receive requests on how to license individuals and how to keep the workforce in place. So as we began to gather that information, not only from a workforce perspective, but also from individuals that were trying to obtain licenses, we began to collect all that. And on March 23rd is when we began to issue some additional executive orders, which we recognized licensed medical profession from other states in certain professions. It wasn't necessarily obvious that it was just your nurses or your physicians, but also we had requests for individuals in the dietitian world and there and beyond. So we really tried to take a very focused approach on those that we needed to really keep the wheels on the bus and to keep things going. So the executive orders began. We began to issue executive orders in our Medicaid program that were specific to telehealth and allowing for some audio-only visits. Also, our Medicaid program had some parameters in place that if you lived within a certain mileage from physicians, you were unable to do telehealth services. So we just made those obsolete. Later on, as we started rolling out our vaccines, and we allowed for some scope of practice changes and allowed for dentists to be able to administer vaccines. So we were really functioning off of executive orders. And then fast forward to where we were at in January, from April to February of this year, we had in our Medicaid program of 140,000 individuals, we had almost 82,000 telehealth visits. And so as we looked at that from a state, and as Jamie indicated in her presentation, is we really did move 10 years ahead in terms of technology and licensing and how we face things. And so what we've done now as a state in the Medicaid program is we're looking to make what we did in those executive orders permanent. As we're starting to make state plan amendment changes, if we can get individuals to go to the doctor via telehealth and to get the healthcare services we need, and individuals are utilizing those services, then let's make that permanent. So we made some state plan amendment changes. Our legislative body convened on January 12th. I think we were one of the only ones in the nation that had an in-person legislative session. It's a 40-day session. We just ended. Well, our veto day is March 29th, but we just ended. And we brought forward pieces of legislation that would move many of those executive orders to be permanent. The first being what we refer to as House Bill 1077 in the state of South Dakota. And House Bill 1077 recognized over 20 professions, in that we will recognize the executive order indicated that anybody from any state with a license could come here to South Dakota and begin practicing. We moved that forward to say that any profession in these 20 specific professions that wanted to come to our state licensing boards, we would recognize that license and to break through some of those barriers. And where we saw this as a big win is it's not very often you get to take a trial run at legislation to see if it works. And so back in 2018, we had members of our legislative body that had in the former Governor Dugard administration had brought forward legislation to try to recognize some of these same licenses and try to break through some of those barriers on licensing. And it was met with a ton of opposition. There were people lining up to defeat that bill, and it did essentially die. So as we jumped forward through the pandemic, through the executive orders, and brought this legislation forward, we did not have one opponent on that bill. And many of the talking points were, see, the boogeyman didn't come out of the closet, everybody is okay. We were able to say for the past year and up until July 1, which our executive orders run through, is we had not received one complaint to our licensing boards questioning anything that had happened in those medical professions and with their licenses. So that bill moved forward. As we were doing it, we actually had some that were outside of the executive order, athletic trainers, funeral directors, that came forward as well that said, hey, we want to join this as well. And so that bill was passed and signed by the governor. In terms of telehealth, I mentioned that our Medicaid program made many of those flexibilities that we did through the executive orders permanent. They're doing those through state plan amendment changes. But what we also wanted to do in our scope of practice laws in the telehealth section is we removed any reference to telehealth. We had in our statute saying that telehealth could not be audio only. And there were also some references to fax and whatnot, fax machines. What we did is we just removed some of those outdated technology references, and so that individuals could access telehealth through audio only, and doctors, physicians don't need to be concerned with their scope of practice. The other big change is there was a requirement in our telehealth laws that were put in place in 2017 to require that you had to have a prior patient-provider relationship before a telehealth service could take place. And we struck that language knowing that it's okay to establish that patient-provider relationship via telehealth, especially in the mental health world. When an individual needs to seek services, we want to make certain that that individual has the ability to get that service when they need. And we had many individuals that came forward and supported that bill, and that was also signed by the governor. So we're very excited with the progress that we've made in South Dakota, and we faced some many difficult challenges, some very difficult times during COVID, but it also catapulted us, to make some decisions that may not have happened for another 5 to 10 years. And I think everybody is truly comfortable and excited with some of the developments that have taken place. And so that's where we sit in South Dakota, with some advancements in our licensing and also some advancements in telehealth.
Excellent. Well, thank you very much, Melissa. Let me share this again. Okay, and our next speaker is Lauren Hibbert, the Director of Vermont's Office of Professional Regulation. Lauren has worked at the Office of Professional Regulation since 2011, serving in the roles of Chief Prosecuting Attorney and as General Counsel for the Licensing Division before taking on the Director position in June of 2018. She is a graduate of Northeastern University School of Law and Mount Holyoke College. Lauren, welcome and thank you.
James, do you want to be the driver or do you want to share the screen with me and we can try that technology again?
Let me see. I will let you control that.
Okay, I think I have control. Thank you very much for having me and good afternoon, everyone. As James said, I'm the director of the Office of Professional Regulation. We're an umbrella agency. We regulate 49 different professions. 26 of them are healthcare. And like Jamie and Melissa just stated, the pandemic really catapulted some of our policy objectives, some of them that we weren't anticipating would be catapulted. It's just been a very interesting time, so I'm happy to speak on it. We have 11 professions that are boards and the remainder are advisor professions, which means that there are advisors appointed to direct me as the director to help form statutory rule and policy changes. And we help the administration with closing and opening guidance for all of our professions, everything from tattooists to cosmetologists to mental health. We had to develop a lot of guidance there for a solid 8 weeks. And then as we started to open back up, a whole host of new questions came and they still are coming with changes in scope of who can administer a vaccination, who can prescribe a vaccination, and who can dispense a vaccination. Act 90 was our primary bill. Our governor is restricted in the state of Vermont during a state of emergency. He or she is not able to modify statutes. Only the legislature can modify statutes. He or she is able to modify rules. So our governor, Governor Scott, did modify many rules, but he was constrained in statutory changes. Fortunately, the legislature was in session when COVID happened. And we, one committee, the House Health Committee, in conjunction and communication with the Senate Health Committee, assembled the primary stakeholders, and we had a long session in a small conference room. It's kind of shocking to think back on it. There was probably 25 to 30 of us in the same room, maybe a 20 by 40 room. It's just in pandemic hindsight, it's shocking. The key components of that bill was telehealth across state lines without licensure, the ability to practice in Vermont. So to physically be in Vermont and practice in Vermont, if you're an out-of-state licensee with just a simple registration on our office, not a license. The ability to issue an emergency license to all people within our program who were unable to take exams. This was not only healthcare related, it was also an engineer who could not take an exam. We have been issuing emergency licenses for those folks. Like many other states, it allowed retirees to practice with either an emergency license or a simple registration. It did also allow the director, myself, to act on behalf of a board if they can't form a quorum. In the very beginning, I utilized that power quite a bit for things like diversions and disciplinary matters. Then we enacted through our emergency rule process, emergency rules for remote hearings, which we hadn't had previously. And since probably June, we have had disciplinary hearings with boards through Zoom. It's actually gone very well. This act also had the ability for the director to issue emergency orders. I did issue several emergency orders, notably, and it received some press coverage, we had an unlicensed MMA promoter and fighters wanting to hold a mixed martial arts event in COVID with children fighting. So I did issue an emergency order to shut that down. I've been very grateful to have that power ultimately. This bill was originally tied to the state of emergency, and then it was modified in the summer to extend through March 31st of 2021, which is coming up very quickly. So we have a pending bill that is now on the House side to extend out these principles from Act 91 until March 31st of 2022. That date was debated in the legislature. We settled on that date. The legislature on the Senate side settled on that date because in March of 22, the legislature will be guaranteed to be back in session, and we can extend those provisions at that time if needed. This bill, S87, is currently pending. It takes all the key components of Act 90 and it sets up sort of a triggering conditions. So if there's another state of emergency, all of the Act 90 provisions would go into effect. This was one of our lessons learned out of COVID. The legislature does not feel inclined to change the governor's authority in a state of emergency to change statutes. So this has triggering statutes that go into effect the minute that any governor would put on a state of emergency, whether it's a health emergency or a natural disaster emergency. The backdrop to all of this is during the COVID response, we've also been working on some key components for streamlining licensure, trying to increase mobility, reducing costs for our licensees, and increasing access to professional licensure for underserved groups. This has been done through a federal grant with the Department of Labor. And we have legislatively last year, we put through fast track endorsement for 3 years after active practice in a different state. That effective date is April of this year. We also have a second chance determination. This is if you have a criminal background before you obtain education or qualifications, or in the midst of obtaining qualifications, you can submit an application to our office for $25 and we will let you know whether your criminal background will prohibit you from the career path you're trying to pursue. We also have a continuing education sunset review provision that on every 5 years, every profession under our umbrella will review its continuing education, make sure that it's continuing to be important and add value to the licensed professional. The rationale behind this is a provision that doesn't necessarily speak for itself, but if you ever have had a professional license, you understand that continuing education can be expensive and a burden as opposed to always a benefit. I think as regulators, we're inclined to think more is better. We just want to put that to the test and make sure that what we are requiring of licensed professionals continues to be appropriate. We also are putting through administrative rules through our administrative rule process. I realized that I put ICAR there and none of you understand what ICAR is. It's so ingrained in my vernacular that I didn't think to spell it out. That's the Interagency on Administrative Rules. That's our first step in the APA in Vermont. For the rule is targeted for people who are trained in a foreign jurisdiction and whose credentials may not naturally or inherently correspond with the career path as someone who's trained in the United States. And then the other big policy goal that we're working on is the Nurse Licensure Compact that is pending in the legislature, and hopefully that will pass this year. Listening to Jamie and Melissa, I just wanted to say, particularly with telehealth, that we do have a study committee that's coming through the legislature on telehealth. I'm going to go back to their presentations on what their states have done to help inform our study group, because it is a study group that the Office of Professional Regulation is responsible for, with multiple stakeholders, every association for every health care group that we regulate and that is regulated in the state of Vermont. And we will be coming back to the legislature with a recommendation for how to permanently change telehealth in the state of Vermont. And with that, I say thank you, James.
There we go. All right, I will take back control of this. And our next speaker is Marshall Smith, the Executive Director of the Interstate Medical Licensure Compact Commission. Marshall came to the director role at IMLCC in October of 2017 after more than 9 years working in healthcare licensing. Sorry about that. Let's see. Okay, sorry about that, Marshall. And let me see. And he came to the director role at IMLCC in October 2017 after more than 9 years working in healthcare licensing for the state of Colorado as the Professional Standards Program Manager at the Department of Public Health and Environment and the Program Director of the Colorado Medical Board. He holds a Master's of Public Administration from the University of Colorado at Denver and a Bachelor of Arts from Drake University. And I can advance these slides for you, Marshall.
All right. I think we went ahead a couple too many, so, or I can just start from there. And thank you, Adam and James, for the invitation to be a part of this presentation and an important topic that as we're coming, knock on wood, on the tail end of the COVID crisis, it's good to start actually looking back and look at what we did, what the successes were, what things we should have done better or could have done better, and then how do we want to plot this moving forward. And so I'm going to talk a little bit about compacts, specifically about the medical compact, and to that. But I also have to, I'm old school enough that you always start a presentation with a joke. So the joke of the day that my brothers and I all share, the joke of the day today was, in the olden days, excessive use of commas was considered a serious crime. It usually resulted in a long sentence. Okay, so let's go back to compacts. So the Interstate Medical Licensure Compact is like all other compacts, and it's in what it does, what it's able to accomplish, and its intention. Compacts are actually a part of the US Constitution, for those of you that love history like I do. And what it is it was a mechanism that was created that allows states to act as sovereign entities in the country and create a national process by which they could come to an agreement between those states to accomplish things. Some of the oldest ones were between states and related to water usage, rivers, watersheds. The healthcare field and using compacts to deal with the healthcare areas is a fairly recent phenomenon. And there, I have wonderful colleagues that run a nursing compact. There's an EMS compact. There's a well, I'm physical therapy, and there are all sorts of compacts that are out there, and they're excellent. We're okay on this slide right here, James. That run compacts. One of the primary differences between the medical compact and most other compacts that are out there is most compacts are a right to practice, if you'll let me say it that way, compact, which says if you are licensed in one compact state, you have the right to practice in the other compact state, other states that are a part of that compact. You're not getting a separate license to practice in all of those states, but you're gaining the authority to practice there by virtue of having a license in a compact state. The IMLCC, or the medical compact, is different in that our compact usage is that the physician obtains a license in every single one of the states in which they intend to practice, and then puts that that license that's been issued then under that board that has issued the license. It puts them under their Medical Practice Act and the authority of that board. And but other than that, it's one of the primary, or one of the only differences between our compact and other compacts. The map that's up there, it shows all of our current member states. We are working with Georgia, Oklahoma, and Vermont to They're issuing licenses right now under the compact, and they're not actually able to act as a state of principal license. A state of principal license is a state where the physician already holds a license and is the key to the entry into the compact process. We are working with Louisiana and the District of Columbia to get them onboarded, and we're also working with Pennsylvania to resolve some issues that they had regarding implementation. So our compact deals with physicians of medicine, MDs, and doctors of medicine, MD, and doctors of osteopathy or DOs. The core to our requirement is they hold a license already in a member state, and that member state then has all of the primary or core data that is needed for that physician to be able to do it. The compact is run by all of our member boards, and so all of our member states, they all have commissioners. We're not controlled by any one state. We're not controlled by any other organization. We are our own organization. So next slide, please. So what we do is that it's basically a two-step process. The physician has to select a state of principal license and goes through their qualifying process. That takes about 30 to 40 days, calendar days to get that done. But once that happens, that physician is then issued what we call a letter of qualification. And that letter of qualification is a key, and was a key during this COVID situation, that allowed for obtaining multiple licenses very quickly. So once this first step has been met, and then we could go to the next slide, please. So these are the requirements, and all of our states have agreed that if a physician has a state of principal license and it's completed step one, which then gets them the access to participate in the compact, if the physician meets all of these criteria, all of our other member states will issue a license without having the physician go through the traditional process, and will not verify the information from primary source because it's already been done. So they went to an approved medical school, they completed the examination within 3 attempts, they had graduate medical education, they're board certified, they don't have any criminal convictions, so we do a criminal background check. There are no history of licensure actions. They have a clean DEA history, no active investigations, and they have to do a criminal background check. So those are the 9 standards. Physicians who then meet those criteria, and we can go on to the next step, are then issued licenses upon payment of our fees that we have to run the compact. That process, we and especially during the time of COVID, is our average is about 7 to 10 days. So a physician who is interested in participating in the compact, they have their letter of qualification, they've gone through that first step and they've met all the criteria. They can then get licenses from any one of the other 31 member boards within 7 to 10 days. And we actually had those situations occur. We actually were able to work with physicians that were in critical situations and needed to be licensed very quickly. We actually got the process done in about 2 or 3 days. And that's working with our member boards and working with the physician and getting all of that done. So we were able to react to the crisis. There is a cost. The compact charges about a $700. We charge a $700 fee to participate. $300 goes to our state of principal license. $400 comes to the compact. There's an additional license fee and there's a renewal fee that we charge in there. The important thing about that, and we're actually going to be conducting a study to look at our fees and make sure that they're appropriate. But for a physician getting 2 to 3 licenses, it actually makes financial sense to use the compact rather than a traditional method and pay for the requirements there. But we're going to be looking at that and studying that. So if you go to the next slide, here's really the key thing that happened with the compact. And I cannot stress enough the amazing work that the licensing staff at all of our member boards did. I mean, we saw a 23% increase in our application volume, and we saw almost a 30% increase in the number of licenses being issued by our member boards during this. I like to say that the compact and our member boards and the licensing staff at those member boards, we were the quiet, effective, efficient people that were behind the scenes. We did our job. We were the right process in the right place at this unfortunate time. And what we were able to do is get physicians licensed quickly where they were needed. And we did that without a lot of fanfare. The licensing staff at our member boards, I mean, it's just phenomenal what they were able to accomplish. So, and this is important to understand this because there are a lot of numbers out there flying around. There have been a couple of different reports about the IMLCC isn't effective because we aren't reaching enough physicians. Those numbers aren't correct. And so we're working on trying to demonstrate what the real numbers are and then try to undo some of that misperception that's out there. So we started in April of 2017. And since that time, we have processed over 12,265 applications, meaning 12,265 physicians have used the IMLCC to obtain multiple licenses. And there have been over 17,000 licenses issued from all of our member boards throughout that process. And then I broke it down next by calendar year. So you can kind of see the growth in the compact, and you can really see it in calendar year 2000, where we saw a significant increase in the number of applications and the number of licenses issued. We almost doubled the applications received, and we doubled the number of licenses being issued. We also, and I'll talk a little bit about what we believe that indicates and why those numbers show that the compact was actually effective at addressing the need to get physicians licensed in multiple states. So pre-COVID, which the 12 months before then, this is our third breakdown of the data, we processed about 3,700 applications, and there were about 3,800 licenses that were issued. Most of our data up to this time was showing that most physicians were getting 1 to 2 licenses, and they were using the compact to expedite that process. What that indicates, and it's anecdotal information that we're trying to get a better understanding of, but what it means is it was a regional licensure thing. So a physician in Minnesota was getting licensed in Wisconsin and Michigan because those were close states. They could open practices, they could work at rural and underserved hospitals and those sorts of things. And that's what we were seeing happen. If you look at the 12 months of the COVID pandemic, which is March 2020 through February of 2021, we processed 5,282 applications, which meant there were almost 6,000 physicians that used our process, and there were 8,000 licenses issued there, meaning the average number of licenses was 3 to 5 licenses per application. That indicates an increase, we believe, and it's again anecdotal information that we're trying to get the solid information behind that. But it meant that telemedicine was used. Physicians using telemedicine to deliver their medicine was used because now they're getting 3 and 4 licenses per application as opposed to 1 to 2, meaning that they're going to be practicing in multiple states, and they're expanding their practice beyond just the physical abilities, but into the realm of being able to provide this using this new method of providing medicine to their patients. So we're still in the middle of some of this, and we're still kind of analyzing it and trying to figure out what it all means. We knew in the pre-COVID era that about 25 to 30% of the physicians that used the compact self-identified that they were using they obtained those licenses so that they could practice telemedicine. We believe that the numbers will be even higher when we start looking at the pandemic information and start getting that information there. The other thing that we knew that we saw a lot of use of the compact were physicians that are doing locum tenens work, which is they were filling in slots where they were needed in hospitals and critical areas. And it allowed them the flexibility to quickly find an opportunity where they were needed to be able to get the license and then start practicing quickly. So they could see an opportunity, they could have their license, they could start practicing in 7 to 10 days after that opportunity came forward. So again, I can't stress enough how incredible our member boards were in reacting to this. They and the staff that met the challenges that were faced in the COVID, working remotely, doing all of this sort of stuff, but they stepped up to it, and we doubled our processing, and we doubled the number of licenses that we've been issued. These numbers represent our total numbers, represent depending on where you're looking, but the latest information that we had that was from 2018, the total number of physicians that are licensed in the United States, we have about 1.38 something % of all of the licenses issued to physicians in the United States were issued through the compact process. And I think that's an important number. It sounds like it's a very small number, but it put into the context that about 5% of all physicians practice or report that they practice in multiple states. We've got a fifth of the physicians that are actively doing that using the compacts. So, and then if we could go to my last slide. So here are some of the lessons that we've learned, and then I want to pose a couple of questions and just as points of contact or points of for people to start considering as they're moving forward. So I believe that really there is not one solution. When you're in an emergency situation, there isn't one solution that works for everybody. And I know there's lots of talk about creating a national licensure and national, one license lets you practice everywhere and create this massive reciprocity. But I think that goes contrary to the lesson that we actually learned as a result of the COVID situation, which is a combination of these emergency rules, a combination of all the states acting quickly and effectively. As you heard from the other presenters, the states saw a problem, they solved the problem for their citizens and for their state. And having these combination of different rules and different ways to do it actually created an effective option and a safe method to ensure that physicians could practice where they were needed. And so I think as hard as it may sometimes be to accept, the system really worked. And it worked because we had the tools in place to allow it to work and the flexibility for the various states to be able to react the way that was appropriate for them to act and to address the situation. While I think reciprocity actions are important, I think they do have a limited function, and I'll pose the question and kind of explain a little bit more why I believe that to be a true statement. I think we have to do a better job to make sure that we're ready for the next crisis, because, as a historian, there will be a next crisis. And let me tell you, we don't know what that next crisis is going to look like. If a year ago someone would have told you that, most of our workforce would be working from home and we wouldn't be going to sporting events and all these sorts of things, they would have told you you were crazy. There's a comedian that has this great skit that she does where she's talking to her future self as COVID starts to happen, and she does it every she's talking to her future self 2 months in advance and telling her things that are going on, and she's acting incredulous about all of that. I think the same thing will happen here. Part of what we've realized is we've got to improve the background check. That was one of our biggest hindrances, where physicians could no longer physically go get their fingerprints done so that they could get their fingerprints. There are options out there that are available that states and can take advantage of, working with the FBI, things like RapBack, where once you have a fingerprint-based background check done, you can access the system again without doing another set of fingerprints to make sure that nothing else has happened. I think there are data banks that we need to put together for reciprocity use for states to use, so that you can go to one place and look at the number of physicians that are licensed, or if they're telling you information, you can go to different places to answer those questions. So next, what I want to do, and I know I'm reaching my time, and I'll wrap up very quickly. I just have some points that I think are important and that should be considered as they're moving forward. I also want to put the disclaimer in that these questions and these ideas are not endorsed by the IMLCC or the compact. They're my opinions and they're my questions that I'm putting forward. So if anyone says Marshall Smith said this, I'll have to go back, point them back to this video and point out that I put that disclaimer in. But as we start moving forward and looking at medicine specifically, I think the first question is, with regards to telemedicine, the question needs to be asked, is this a new form of medicine, or is this a new method by which medicine is being provided? The answer to the first question, if it's a new form of medicine, then yes, it would be appropriate to come up with new mechanisms to license and to regulate the physician that is using that. If in fact it's the answer to the question comes down to no, it's the practice of medicine, it's just a different way to provide it, then I think our current structure and our current makeup of licensing, reciprocity, and all of those sorts of things in the practice of medicine in the states, I think they're then still valid, because the practice of medicine should be the practice of medicine, and it shouldn't be changed or amended based on how that medicine is provided to the patient from the physician. The second question I think that is important that people start to ask is that, what are the patient's expectations regarding their care? I know that as someone living in Colorado, I'm expecting my physicians that I see or my family sees that they're following the Medical Practice Act in Colorado. But if I'm remotely talking to a physician who's in, say, Washington State, are they following the Medical Practice Act set up in Washington State, or are they following the medical practice in Colorado? And what are my expectations, and how should those expectations be set to me? And I think that's an important question as we start talking about making this easier for physicians to obtain licenses and practice over state borders, is answering it from the patient's perspective. And then related to that is, what Medical Practice Act governs the care that's provided? Because every state has a different Medical Practice Act, and there are important differences between those states, and those states and their citizens have established that as how they want medicine practiced in their state. And where does that reside? Currently, the practice is that it resides where the patient is located. That is the expectation and the standard of the practice of medicine. And finally, I think it's important that, especially as we were as a country, before COVID hit, we were dealing with the opioid crisis. And some of the answers to the opioid crisis was a lot of states created prescription drug monitoring programs. Are those still in effect if you have physicians crossing state boundaries? How does that work, and what sort of requirements? If the physician is licensed again in Washington and I'm a patient in Colorado and I'm being prescribed opioids, is the PDMP being reported in Washington State, or is it being reported in Colorado, and what sort of controls are things there? So I think it's important to keep in mind past problems that we've done a very good job of solving, and not erase the gains that we've made in that field. So, and with that, thank you for indulging me and letting me get on my high horse and talk about a subject that really is something very important to me, and it's something that I believe very passionately about. I do think, in closing, that the compact and our member states reacted to the situation, and also kudos to all of our states out there that whether they're part of the compact or not, they came up with ways to provide healthcare to their citizens. And I think an important lesson and a final thought is that, you know, the situation we faced and will face again is too complex for one single answer. We keep hoping there's a silver bullet, but there isn't. And I think having traditional licensing, compact licensing, reciprocity, all of those things are important to broaden the tools available rather than try to find one way to do it. So thank you all for your time, and happy to answer any questions.
All right, thank you very much, Marshall. And let me see. So I did include all of our contact information on this slide as well. So if we're more than happy to take questions in the chat box, and also if you have any questions for any of the presenters or myself, feel free to send us a message. And you can also access this webinar, the recording of it, after just about a week on our website, licensing.csg.org, and that along with the database and the report that we had published previously. So let me check. So we did have a few questions for you, and this is a bit more open response, but let me see. Do you feel that your state is more prepared to respond to a future emergency, or are further steps necessary? And of course, this would be directed towards the state licensing people on the call. Oh, go ahead, Laura.
I'm happy to respond first. I think that Vermont is more prepared. First and foremost, there's new state partnerships that have been forged through the pandemic, tighter communication between the licensing agency, OPR, and the Office of Professional Regulation and the Department of Health. We're in much more consistent communication. I also think that bill that's pending, S87, is crucial to the next pandemic response. Again, Vermont is somewhat atypical in that the governor cannot modify statute. And so those triggering provisions that happen if and when the next state of emergency is issued, I think will be very helpful.
I'll take a minute on that one as well.
Please go ahead. Thank you.
Our state has been through many emergencies in the past. We have not seen a crisis of this capacity in terms of a health emergency, but because we do have a history of hurricanes and weather-related emergencies, we had a lot of legislation that was able to support all of the needs of our agency, and the governor had the provisions to write those proclamations and make those changes as needed and necessary. So I think of course there's always room for improvement, but because we are a state that's used to natural disasters, unfortunately, we did have a lot of statutes and provisions that we were able to use to utilize our resources and get things moving pretty quickly.
Excellent, thank you. And let me see. Okay, let me check the chat box. And I'm sorry, Adam, do we have any other questions coming up through there?
Not from the chat box, no.
Okay, well, I think we are closing in towards the end of our time. So if there are any last words or anything that anyone would like to give us before we let everybody go, feel free. If not, we can wrap things up here. All right, well, thank you very much to all of our presenters. And once again, this presentation will be available on our licensing website. Just give us about a week on that. And everyone have a great day.